Hello, my name is Sierra Schaller-Mahl, and I'm a family nurse practitioner student at Spring Arbor University. This is my presentation on a quality improvement proposal on an evidence-based practice change. Gestational diabetes mellitus is the most common pregnancy complication in the world and in the United States. Worldwide, 1 in 6 births is impaired by gestational diabetes mellitus, with 10% of pregnancies in the United States having gestational diabetes. Gestational diabetes doubles the morbidity and mortality rates of the fetus and mother, with the United States having the highest morbidity and mortality rates of pregnancy in developing countries. 90% of pregnancies with diabetes is due to gestational diabetes mellitus, not type 1 or type 2 diabetes. This is imperative to note as women with gestational diabetes mellitus have no experience with diabetes. This includes no diabetes education, treatment, or management familiarity, and they are unaware of complications short or long-term from hyperglycemia. The severity of gestational diabetes is directly in proportion to the severity and duration of hyperglycemic episodes, making management crucial. However, there is a high rate of non-compliance with self-blood glucose monitoring. Without glucose data, providers cannot determine interventions for this disease process, bringing about the PICOT question. In pregnant women with gestational diabetes mellitus, how would a continuous glucose monitor compared to a self-monitoring blood glucose check schedule affect the glycated hemoglobin, the A1C, during the 3rd trimester of pregnancy? The objectives are to normalize the A1C to less than 6.5% in the 3rd trimester at 36 weeks gestation. This in turn should lead to the objective of decreasing rates of C-sections due to fetal macrosomia and NICU admissions related to gestational diabetes, with complications being reduced by 10%. The concept model guides the quality improvement process by keeping the team on target. This identifies the patient population, which is patients with gestational diabetes, the intervention, which is CGMs, the goal, which is a normal A1C at or less than 6.5%, as well as the timeline, which is 3rd trimester. The quality improvement process has 4 phases: education, development, implementation, and evaluation. The quality improvement process purpose is to determine in pregnant women with gestational diabetes, how would a continuous glucose monitor compare to a self-monitored blood glucose check schedule affecting the A1C in the 3rd trimester of pregnancy. The objectives are based on improved management of diabetes through hyperglycemia awareness, prompting intervention. The A1C will be less than 6.5% in the 3rd trimester of pregnancy, in turn decreasing rates of fetal macrosomia, C-sections, and NICU admissions. The first phase is education. The Commonwealth Health System Diabetes Clinic certified diabetes educator nurse will provide a 2-day workshop to the staff of the OB department to familiarize them on CGM usage. Staff can either come in on their day off or during this workshop. 2 additional staff members will be added on to cushion the staff levels during these workshop days to help run patients and to ensure that all staff can attend. We will also alter the provider schedule, decreasing the patient load to ensure the providers can attend. Most of the providers are salary, so this does not alter the budget, and the CDE-RN will be reimbursed through the education budget. Breakfast and lunch will also be provided during these workshop days to increase staff attendance. The education will begin 1 month before the practice enactment. Phase 2 is development of the policy. We will compare the policy on CGMs at the Commonwealth Health System Diabetes Clinic and adapt them for a policy on CGMs in the OB clinic. Phase 3 is implementation. We will ensure that all staff are completely trained and they're educated on CGM use. We will finalize and activate a policy on the CGMs in the OB clinic. We will determine guidelines on selecting patients eligible for CGM use. This will be done in coordination with the authorization specialist to ensure the correct coding for insurance reimbursement. Clinicians can then discuss the CGM treatment option with patients and record which patients opt for a CGM and which opt for self-monitoring blood glucose level. The IT department will also be contacted to see if there's a way to log which patients opt for treatment option for data evaluation. Phase 4 is evaluation. We will obtain baseline A1Cs for all newly diagnosed patients with gestational diabetes mellitus. We will also obtain an A1C with those currently diagnosed. We will then review quarterly reports on C-sections and NICU admissions. C-section rates, C-section indications, birth weight, and NICU admission indication records have been kept since the 1970s. These logs are in the manager office. This is great for retrospective examination of data to determine intervention effectiveness and trends. Because these logs are already kept, identifying this information does not add a new work burden to the staff. We will then determine the number of C-sections and NICU admissions related to gestational diabetes. This project can be coordinated and adopted by the Unit Practice Council. The Unit Practice Council meets for an 8-hour day every month with quarterly staff meeting presentations. With the A1Cs, we will get a repeat level at 36 weeks gestation. At 36 weeks gestation, this is acute as GBS cultures are performed during this time, as well as ultrasounds to assess for fetal growth. Therefore, adding an A1C level will be convenient at this time marker. At 24 weeks to 36 weeks is a 12-week window. A1Cs are accurate with 3 months as it determines the average amount of sugar on red blood cells. This 12-week window is perfect for determining A1C changes or maintenance. The APN will then meet with staff weekly for the first month to assess the understanding of the CGM applications. They will also discuss if the staff is able to read the reports and ensure that the CGM websites are fully maximized, including interpreting logs, identifying glucose trends, identifying the glucose time and euglycemia ranges, and the time spent out of range, whether it be hyper or hypoglycemia. This will also coordinate if trends are noted on weekends, weekdays, in the mornings or evenings. They will also ensure that all providers do not have any issues with username and login to address the system. The AP then will meet monthly with all staff members for at least 6 months to ensure long-term engagement. Timeline, resource, and costs. Staff education will begin 1 month prior to the go-live date. The staff workshop will occur for 2 days with the CDE-RN expertise training. The pilot program will begin in 1-month increments. Monthly reviews of the rates of C-section indications and neonatal NICU admissions related to gestational diabetes will be performed monthly by the Unit Practice Council. The APN will meet with all staff weekly for a month and then monthly for 6 months to ensure long-term application. The Commonwealth Health System has active user-provider patient agreements with the CGM companies based on the diabetes clinic, so this will be at no additional cost to CHS. CGMs are personal medical devices paid for by insurance companies. The 2 days of full work time for the CDE-RN is negligible and will be covered by the education budget. The 2 hours of education for each department and the staff in a small group setting is negligible as it will be obtained during the workday for most staff members. No additional equipment is needed for this practice at no cost to CHS. When implementing an evidence-based practice quality improvement project, it's important to assess the organizational readiness. The Commonwealth Health System has substantial readiness based on the Agency for Healthcare Research and Quality Readiness assessments that were performed. The CHS vision is to create places where people choose to come for healthcare, providers want to practice, and employees want to work. This is also in line with the clinical practice guidelines of caring, which is all providers and staff within the Commonwealth Health System have compassion, always put the patient first, treat everybody with respect, encourage innovation, have no excuses, and a great attitude. The providers will likely engage in this practice project because it gives them information needed to make their clinical decisions. Patient demand will likely drive this practice due to the elimination of pain from the procedures. The only barrier to this project is going to be which patients are candidate for CGMs, which we will work through with the insurance companies for reimbursement and coding. So how imminent is this problem? Gestational diabetes mellitus is the most common pregnancy complication, impairing 1 in 6 births worldwide and 10% of pregnancies in the United States. Gestational diabetes increases the lifelong risk of type 2 diabetes for both the mother and baby. For the mother, it increases her risk of type 2 diabetes 7-fold in her lifetime, with 50% of these women developing type 2 diabetes. The maternal complications include spontaneous abortion, pyelonephritis, preterm labor, preterm birth, polyhydramnios, preeclampsia, and an increased risk of C-sections. In addition, from the diabetes, there is delayed wound healing from the cesarean births. Neonatal complications include stillbirth, macrosomia, shoulder dystocia, brachial nerve plexus injuries, neonatal hypoglycemia, hyperbilirubinemia, hypocalcemia, polycythemia, hyperinsulinemia leading to hypoglycemia episodes, delayed lung development, and fetal hypoxia. This in turn increases NICU admissions and traumatizing the baby and mother from separation at birth. Cumulative pain from the numerous daily finger sticks and pricks becomes a deterrent to compliance, as well as having to carry the diabetes supplies for testing at all meals and snacks. 2-hour postprandial glucose levels are often missed as patients forget to take their blood sugar 2 hours after a meal, or they snack in between meals, interfering with the sugar levels. A CGM measures glucose levels every 15 minutes through interstitial blood glucose monitoring. This greatly reduces the need for finger pricks while providing more awareness in controlling gestational diabetes. A CGM provides 288 readings of glucose levels a day compared to a self-monitoring blood glucose check. This is also important for determining glucose trends, as an SMBG determines the glucose level at a point in time and does not determine if the level is going to further increase unbeknownst to the patient and provider, or if it's decreasing leading into hypoglycemic states, which are dangerous for both the mother and the baby. In order to ensure successful evidence-based practice transition, the evidence must be reviewed and presented to the staff. Searches of numerous databases, including Cochrane, CINAHL, and Medline, were performed. The key words were gestational diabetes mellitus, continuous monitor, glucose monitors, self-monitoring blood glucose levels. The most successful was Medline, with gestational diabetes, CGM, and SMBGs yielding 61 results. However, results were limited to those in English with a full text in between the years of 2010 and 2021. The CGMs have unprecedented glucose monitoring ability, providing 288 readings every 24 hours. In addition, the duration and severity of hyperglycemia is directly in proportion to the severity of complications from gestational diabetes. The higher the blood sugar and the longer the blood sugar stays high, the more the body is impaired from hyperglycemia. This makes it crucial to maintain a euglycemic state of normal glucose levels as much and as long as possible. Evidence has found that euglycemic states are increased with SMGs compared to SMBGs. The CGM app reveals glucose trends in live time to patients, enabling personalized feedback, including alerts for hyper or hypoglycemia. CGMs capitalize on self-monitoring motivation as patients detect the glucose trends in real time. This can determine if the patient goes for a walk, if they should eat something different at their next meal, if they should change their snacks, or if they should change their habits to prevent hyperglycemia in the first place, as they can detect these trends occurring. It also allows them to actively intervene in hyperglycemic states. The CGM is determined to be accurate and safe for use in pregnancy based on multiple studies, including the CONCEPT study. No side effects or adverse events have ever been identified from CGM use in pregnancy. At this time, question and answers are taken during the presentation. However, I want to leave you with a few questions. Would screening for gestational diabetes earlier help to capture interventions in this patient population? There's increased rates of obesity in the United States, with 2/3 of the population being obese or overweight. Obesity is the primary risk factor for gestational diabetes. Currently, we screen for gestational diabetes at 24 to 28 weeks gestation. 27 weeks gestation marks the third trimester. Would it help to begin screening and treatment at 16 weeks due to the obese population? Another intervention would be dietary interventions. Would it help to have a nutritional consult monthly for patients with gestational diabetes? As 90% of diabetes in pregnancy is from gestational diabetes with no education on diabetes, would a diabetes clinic consult be helpful at the diagnosis as well as 6 weeks postpartum, as many women develop type 2 diabetes later on, which goes undiagnosed? Would a physical therapy program be helpful? Many women are afraid to exercise during their pregnancy, as if the heart rate gets too high, it cuts off blood supply to the baby. Would safe exercising programs for gestational diabetes patients help to reduce gestational diabetes complications? Another study would be to determine the effects of excess glucose levels on the developing fetus. How does excess glucose levels impair fetal development on their brain? Does this increase rates of ADHD? Also, does excess glucose levels affect childhood cancer rates, seeing as cancer feeds off of sugar? Does the fetal hyperglycemia in utero then in turn lead to cancer rates in childhood? Just some questions to think about for future projects. Here is my list of scholarly references. Thank you for watching this presentation.